Welcome everyone to this masterclass on antenatal corticosteroid, and this session is going to be a highly crisp and super detailed, and it is designed for the undergrads, postgrads, as well as the healthcare professionals. You know, the discovery of antenatal corticosteroid changed the entire outcome of a neonate, especially if it's a preterm baby. So let's get started. So out of all the systems, it is the respiratory system, right, which gets matured at last. Okay, so out of all the system, it is the respiratory system which gets matured at last. So the last organ system of the fetus which gets matured, right? There are two very famous scientists, right? This gentleman over here, the Sir Graham Higgins, and this gentleman over here is Dr. Ross Howey. Higgins was a world-renowned obstetrician and Howey was a world-renowned pediatrician, and both of them together, right, conducted something called the famous Auckland trial, and they did that trial with a drug called betamethasone. And the outcome of the trial was that there was significantly reduction in the risk of respiratory distress syndrome in those of preterm babies, as well as the neural outcome and SNCU admission was much lesser. Okay, so compared to the, coming back to the discovery, it is the Higgins and the Howey that did this groundbreaking work. Okay, and as I mentioned already, they conducted the famous Auckland trial, which is related to this discovery of antenatal corticosteroid. Now, starting with the basics, there is something called Whipple's model of airway. All of us have studied this in the first year of med school in the physiology, right? So there are total 23 generations of the airways, starting from the trachea to the alveolar sac. Out of these, I want you to know the last three, and these are the respiratory bronchioles, alveolar duct, and the alveolar sac. Now, these three structures together form something called as terminal respiratory unit, just because of the fact that gaseous exchange happens in this level, the level of TRU, or terminal respiratory unit. Next is the mechanism of action of the antenatal corticosteroid, how it really works, right? So there are mainly there are two mechanisms, right? One major and another minor. But before going back to this, let me zoom a alveolus for you. So if you look at it very carefully, you can see that, so this is a single alveolus over here. And in this alveoli, can you see these flat green cells over here? Yes, they are called type 1 pneumocytes. And can you see these tall blue cells over here? Yes, they are called type 2 pneumocytes. Okay. Now, the type 1 pneumocytes, they are flat cells. And the type 2 pneumocytes, they are the simple cuboidal cells. Now, this alveoli is lined by something called as alveolar fluid, and remember this is the type 2 pneumocytes which are going to produce a lipoprotein known as surfactant. And this surfactant, what is the function of surfactant? It basically reduces the surface tension. So this structure over here, I have drawn it with these violet stars. They are basically surfactant over here. Now, and this blue dotted line, they are representative of the lung fluid or the alveolar fluid. Now, this surfactant reduces the surface tension of the alveolar fluid, and thereby they prevent the end expiratory collapse, okay, when a newborn baby is born. All right. Next, we can see this red channel over here. I'm drawing it with this marker, and they are called something called ENaC. They are called something known as ENaC. They are basically epithelial sodium channel. They are the same ENaC which is also present in the nephrons. Alright, now what is the function of this channel? Now this ENaC, basically through this channel the sodium gets expelled out, and who follows sodium? It is the water. Alright, so thereby these ENaC channels act as a tunnel through which the water is expelled out along with sodium. Now the main alveolar cell which is participating in the gaseous exchange, they are type 1 pneumocytes, as they are covering most of the surface areas. But remember this type 2 pneumocytes, or the blue cells over here, they're also very important, because it is the type 2 pneumocytes which are differentiated into type 1 pneumocytes. So the origin of the type 1 pneumocytes, it is a type 2 pneumocytes. Okay, so type 1 pneumocytes are formed after the differentiation of the type 2 pneumocytes. So I think I have made it clear how it really works, how the surfactant really works. So you can see in this flow chart over here. Now see this this antenatal corticosteroid, right, which is given over here, they basically promote the development of both type 1 and the type 2 pneumocytes, especially type 2 pneumocytes, which are responsible for the surfactant production. Now this surfactant decreases surface tension of the alveolar fluid, and that decreases the risk of post-expiratory or the end expiratory collapse of alveolus. Alright, and also the antenatal corticosteroid promotes the synthesis of the ENaC, which helps in the drainage of the lung fluid along with sodium. Am I clear with this? So there are two key points. One is surfactant over here, and another is ENaC over here. So that sums up the mechanism of action of the antenatal corticosteroid. So yes, so let's talk about the pneumocytes a little bit more. I have already told you that. So these type 1 pneumocytes are the flat cells, and they are covering the more surface area of the alveolus. They're lesser in number, and they are the principal cells which are basically participating in the gaseous exchange. If we talk about the type 2 pneumocytes, they're more in number. They cover less amount or the less surface area of the alveolus, and they're responsible for the surfactant production. And another very important function of them is to get differentiated into type 1 pneumocyte. Now, I'll be talking about surfactant in detail. Now, if you can see in the slide over here, so this is a type 2 pneumocytes, okay? And in them, we have got some sacs, and those sacs are basically having surfactant inside, and the sacs are called the lamellar bodies. Okay, so the surfactants, they're basically stored inside these lamellar bodies. Remember the time period of surfactant production, and that is, now surfactant production starts at 24 weeks, and surfactant production gets completed at around 34 weeks. Okay, now if you see the surfactant, it looks something like that. So it has got a hydrophobic, so like that, it has got a hydrophobic tail and hydrophilic head. So it has got a head which is basically hydrophilic, and tail which is basically hydrophobic, just like phospholipid. Now this lipid part, now look very carefully. Now the major lipid which forms the surfactant is lecithin, and the minor lipid component is sphingomyelin. Okay, and this lecithin is also called dipalmitoyl phosphatidylcholine, or DPPC. And we have got the sphingomyelin as the minor lipid component of the surfactant. As far as the protein is concerned, which forms the head of the surfactant molecule, we have got surfactant protein A, B, C, and D. Out of this A and D, they helps in the lung maturation. Now this is the arrangement I want you to understand over here. Now please focus. So this is a single surfactant molecule. You have got a hydrophilic head and the hydrophobic tail, just like phospholipid compound. Now this head is made up of protein. The protein is charged or polar, so they're water soluble. And then we have got the fat component surfactant. We have got like lecithin and the sphingomyelin as far as the fat component is concerned, and they form the hydrophobic tail of surfactant over here. And they're arranged in form of a micelle, and of course they're arranged in form of a micelle, just like that. And this form gives the maximum stability to the surfactant molecule. There are two kind of tails in surfactant. One is the lecithin sphingomyelin ratio, which is done following amniocentesis on the amniotic fluid, and if the ratio is more than or equal to 2, that denotes proper fetal lung maturation. And another test is something called shake test. So we we take amniotic fluid in a test tube and we shake it. If there is appearance of bubble because of the fatty component, that basically is representative of the the amniotic fluid contains surfactant, which indirectly represents that the fetal lung is now matured. Coming back to the next point, there are a lot of recommendations about the antenatal corticosteroid. We'll be starting with the first recommendation. Now, the main benefit of the surfactant is that it decreases the risk of respiratory distress syndrome by decreasing the surface tension of the alveolar fluid, and thereby preventing the end expiratory collapse of the alveoli in the preterm babies. Okay, next, as it decreases the respiratory distress syndrome, decreases the NICU admission, it decreases the neonatal death to a greater extent, and it also decreases the perinatal death. Okay, now remember one thing is which is very important clinically, right? Now, if in order to get the benefit of administration of antenatal corticosteroid in a lady in whom the preterm delivery is expected or preterm birth is expected, okay, now we need to, the delivery has to happen within 7 days of administration of surfactant. Corticosteroid. Okay, so once you give the corticosteroid, the delivery should occur after 24 hours and before 7 days. So that is the window period when we get the maximum benefit of antenatal corticosteroid maturing the fetal lung, to some extent brain also. Okay, so the window period, it is after 24 hours and before 7 days. Recommendation 2, yes. So the usual time period of administering the antenatal corticosteroid, it is 24 to 36 weeks 6 days. Now, in whom the preterm birth is anticipated, for example, PPROM or preterm birth, history preterm birth, or a twin pregnancy, okay, or a planned preterm birth, maybe because of some abnormal Doppler study. Okay, so in all those scenarios, right, we give antenatal corticosteroid at a period of gestation somewhere between 24 weeks to 34 weeks 6 days. Okay, why 24 weeks? Why not before that? Because surfactant production starts by the type 2 pneumocytes at around 24 weeks. Okay, so if you give before that, it can't do its it can't do its action. So that is very important. Now, there are 3 main benefits. It decreases the respiratory distress syndrome, it decreases the neonatal death, it decreases the perinatal death. Out of this is the elephant in the room. If you have to remember only one benefit, and that is basically decreasing the respiratory distress syndrome. So can you administer antenatal corticosteroid at a period of gestation somewhere between 35 weeks to 37 weeks? Yes, you can use it for fetal lung maturation, right? But it might come with some harm as well. And those are basically neonatal hypoglycemia and some psychiatric and behavioral problems in the baby, right? If you give it at 37 or after. Okay, now neural hypoglycemia, why it happens? Because once you administer antenatal corticosteroid, it is going to cause maternal hyperglycemia for first 5 days after administration of antenatal corticosteroid, and this maternal hyperglycemia will subsequently cause fetal hyperglycemia, and it will cause fetal hyperinsulinemia. So once baby is delivered, you're cutting off the source of glucose, which is the maternal blood glucose, but still the fetus has got increased insulin level in its blood, which is subsequently going to cause the fetal hypoglycemia. I hope it's clear. Now, in case of like elective or planned cesarean, right, somewhere between 37 to 39 weeks, you might give antenatal corticosteroid after discussing the benefit and the harm of antenatal corticosteroid to the parents. Okay, now what are the benefits? Yes, definitely it decreases the respiratory distress syndrome, it decreases the TTE and the transient tachypnea of newborn, and it definitely decreases the SNCU and NICU admission. All right, what are the harm? So now several studies have shown that if the antenatal corticosteroid is administered after term pregnancy, it is going to decrease the IQ of the baby, okay, which is thereby going to decrease the academic performance of that particular kid. It is associated with neurodevelopmental delay and delayed developmental milestones, and immediately it might cause neonatal hypoglycemia. I've already told you the mechanism by which it is going to cause neonatal hypoglycemia. It is seen because of the neonatal hyperinsulinemia as a result of maternal hyperglycemia as a result of antenatal corticosteroid administration. Okay, now antenatal corticosteroid administration in twin pregnancy is same as single month pregnancy. There is no role of routine antenatal corticosteroid administration in multifetal gestation. Okay, so they are just the same. All right. Now these are the benefits of the antenatal corticosteroid. Now, in very crisp, in very consolidated fashion, I can say that the antenatal corticosteroid, they are responsible mainly for the fetal lung maturation, and to some extent it also leads to fetal brain maturation. Okay, now what are the benefits of the fetal lung maturation? Yes, it is going to decrease the respiratory distress syndrome, and it is going to decrease the neonatal death. It is also going to decrease the prenatal death. I already told you the mechanisms, right? It is also going to decrease the risk of intraventricular hemorrhage in a preterm baby. Okay, and intraventricular hemorrhage usually occurs because of the leaky capillaries and the immature blood-brain barrier, right? And several studies have shown that the risk of IVH or intraventricular hemorrhage is significantly reduced, right, with antenatal corticosteroid administration. Okay, but it also comes with its drawback, which is basically the developmental delay, decreased IQ, delayed developmental milestones, and the neural hypoglycemia. All right, now I already told you that, right, the maximum benefit is seen if the delivery happens. Now this is the most important slide in this entire discussion. The maximum benefit is seen if the preterm delivery happens within if the preterm delivery happens after 24 hours but before 48 hours of corticosteroid administration. All right, if the delivery happens within 24 hours of corticosteroid administration and after 7 days of corticosteroid administration, then there is practically no benefit. The maximum benefit of the corticosteroid happens if the preterm delivery happens after 24 hours and before 48 hours. So that there is, I mean, there is why we can see the maximum benefit. Okay, so this is a very important clinical point for us as a, as a clinicians, as a obstetricians. Now, I already told you that, right? Antenatal corticosteroid is going to increase the maternal blood glucose because corticosteroid is a pro-diabetic hormone, and it increases the maternal blood glucose up to 5 days. Up to 5 days after administration of corticosteroid. Okay, so this is very important. I am to the next slide. Yes, if the corticosteroid is administered at or after term pregnancy, it is going to cause the decreased IQ, neuropsychiatric problems, decreased intelligence, right, increased congenital hypoglycemia, and decreased birth weight and decreased birth length. Okay, so they are the adverse effect of administering the antenatal corticosteroid at term pregnancy. Am I clear with this? There is something called as the rescue course. So a single course of antenatal corticosteroids is given if the previous course of antenatal corticosteroids was given more than 1 week ago, right? So what is a rescue course? So if you have given a corticosteroid, a complete course of antenatal corticosteroid, and for some reason the delivery is not achieved, the delivery didn't take place, and it has been like more than 7 days, of course, if there is still risk of delivery, I mean, we can't get that benefit of antenatal corticosteroid because 7 days are already over. In that case, a single course of antenatal corticosteroid can be given. All right. Okay. If you think that there is a possibility of delivery within 7 days, and if you don't think that there is no possibility, or if you don't think that there is any possibility of delivery, preterm delivery within 7 days, then don't give it. All right. So they're coming with same sort of, right, the advantages as I discussed before. The harm may be because of excessive administration of corticosteroid. Yes, there is decreased birth weight and decreased birth length. Okay, so in case of late preterm or term pregnancy. Okay, so that is very important. Now there are 2 regimes which are used as antenatal corticosteroid. One is dexamethasone, which is more widely used in India, and there is a betamethasone, which is a little bit better regime compared to dexa. I'll tell you exactly why it is so. Now the dose is very important for us as well. The dexamethasone is 6 milligram, 4 doses, 12 hours apart. It is given that intramuscularly, and the betamethasone, right, it is given in a dose of 12 milligram, 2 doses, 24 hours apart, right? Remember this, the risk of chorioamnionitis. Okay, you know the corticosteroid, that immunosuppressant. The risk of chorioamnionitis is more with dexa or beta. The risk of chorioamnionitis is more with dexamethasone. Now, remember this. This betamethasone comes in 2 preparation: betamethasone sodium phosphate and betamethasone sodium acetate. Often they're available in 50 ml. So there is a mixture of 50% of this betamethasone sodium phosphate and 50% of betamethasone sodium acetate. Remember this phosphate, it is more soluble, and as it is soluble, it comes with a shorter half-life. The acetate, it is insoluble, and as it is insoluble, it comes with a longer half-life. So when we have got a 50:50 misc, that gives a very stable, release and very stable half-life of the preparation. Okay, the problem with dexamethasone is that it has got a very quick peak, and the duration of action is of much lesser compared to beta. So in dexa, right, we have got a very early peak onset of action, and then the duration of action is also very less. It is not stable. Compared to beta, especially if we talk about 50:50 regime, right? As it is having this component beta-methazone sodium acetate, it has got a very stable release and it has got a longer duration of action. Okay, and that doesn't cause, maternal hyperglycemic peak. Okay, compared to the dexamethasone. All right. So there are two regimes over here. Now, if I talk about some special cases, now antenatal corticosteroid in diabetes in pregnancy, now especially those mothers who are like having over diabetes or GDM, and antenatal corticosteroid administration is not at all absolute contraindications. However, they are going to increase the maternal blood glucose level. For how many days? For 5 days. Okay, so in that case, for 5 days, you have to increase the dose of insulin. You might need to increase the dose of insulin if there is poor glycemic control, right? So if you use the antenatal corticosteroid at term pregnancy, of course, there is a decreased need for respiratory support and SNCU admission, but it is going to decrease the intelligence and it is going to cause neuropsychiatric problems and neonatal hyperglycemia, all these things, delayed developmental milestones, as we already discussed. So thanks for listening, and if you have got any queries, do let me know in the comment section, and as always, bye bye, peace.